All right, so Elizabeth, you have a case?
Yes. So I just saw this 51-year-old female for chest discomfort. You know, I should start off before I say anything else that she's really anxious. She actually takes clonazepam on a daily basis. So she was in her usual state of health until about 2 days ago when she started to get this just central located chest burning. It would last about 10 minutes and then go away on its own, and it would occur maybe 3 to 4 times a day for the past 2 days.
Okay.
She did get a little sweaty and a little nauseated with it, but I couldn't elicit any shortness of breath or palpitation type symptoms. And she's never had this pain ever before, and she doesn't have a history of any heart disease that she's ever aware of. I will tell you though, she's really anxious and worried about the heart disease because she has a brother who had a heart attack in his 40s.
His 40s, okay.
She doesn't have any orthopnea, and it was really hard for me to tell if she had any shortness of breath with exertion because she complains of this leg pain every time she moves around, so she doesn't really exercise that much. But she is not having any chest pain at this very minute.
Okay, good, good.
Her past medical history, she does have a history of high blood pressure, and she takes hydrochlorothiazide 12.5 milligrams daily. And, you know, she does smoke a pack of cigarettes still a day. She is trying to quit and cut down, but she does smoke that. On exam, she was well developed, well nourished, no acute distress. Had her eyes, nose, throat. She didn't have any JVD that I could see. Her lungs were clear, heart sounds, no murmurs, clicks, rubs. Her peripheral extremities were warm, well perfused. I didn't see any clubbing or cyanosis. Yeah.
So what do you think is going on?
Oh, well, you know, she is so anxious, and I've seen her a couple times before here in the clinic, and usually she's just concerned about whether or not I'm going to refill her clonazepam. So I'm not so worried about this chest pain. I think she's just super, super anxious.
Okay, so what about her presentation makes you reassured that this isn't her heart?
Well, I guess partially the pain, because it's located right here in the chest and doesn't radiate into her jaw or down her arm like I would typically think of chest pain that's cardiac in origin. And you know, she's awfully young and doesn't have any history of heart disease.
Sure. So coronary disease is rough. And it's a tough diagnosis because although we read in the textbooks the patients usually present with dull substernal chest pain radiating to their arm and their jaw with associated nausea and diaphoresis, a lot of patients don't present that way at all. And a lot of patients present with atypical symptoms. And women and folks who have diabetes are even more likely to present with atypical symptoms. And the problem is that when we miss a diagnosis of coronary disease, it's a big deal, obviously. And so we have to set the threshold very low in terms of evaluating patients for coronary artery disease, even if their symptoms don't fit the textbook diagnosis. Does that make sense?
Sure.
Great. So you did some things very nicely. You gave a wonderful presentation. Your presentation, it was appropriately detailed. You talked about everything that I wanted to know in the history, and you described the pain well and all those associated symptoms. I couldn't think of another question that I wanted to ask. And your physical exam was also appropriately detailed in terms of the pertinent positives and the pertinent negatives, which really helped me sort out what I think might be going on. One thing to work on would be your approach to chest pain in general. Because you know the differential diagnosis for chest pain goes on and on and on and on and on. It gets pretty confusing. But one thing that you can do is always be sure that one of the really nasty diagnoses isn't going on. So there are about 5 that you really worry about: acute coronary syndrome, pericarditis or tamponade, pneumothorax, pulmonary embolism, and aortic dissection. And so when you see a patient with chest pain, you want to be pretty convinced walking out of the room that one of those things isn't going on, because the downside of missing one of those obviously is huge. And then kind of gauge your diagnostic workup that way. If this is GERD and we don't make the diagnosis for a week or 2, that's okay. If it's acute coronary syndrome, it's a much bigger deal.
Okay.
Does that make sense?
Mm-hmm.
All right, great. Well, why don't we go see her?
Okay, great.
Great.